Good evening, a very good evening to one and all present. I am Aishwarya Vernikar. I am a part of the marketing team of Samat Life Sciences. And on behalf of Samat Life Sciences, I would like to welcome all the esteemed faculty and delegates who are here, who are joining us here today live for Masterclass in Prostate Cancer on this Saturday evening. So on this occasion, I would like to take the opportunity to introduce Dr. Sanjay Kamble, who is the head of medical of Samat Life Sciences. And I would urge you, sir, to take over the meeting. So I'm handing over the meeting to Dr. Sanjay Kamble. Sir, please go ahead.
Thank you, Aishwarya, and good evening, everyone. And it's been a very nice evening and a very, I look forward for a very informative evening, rather in fact, because we have all the, a group of allied members who will be speaking on some very interesting topics related to the prostate cancer. And you know, prostate is one of the few cancers wherein the people don't die, but there's a lot of morbidity associated with it. And with that, you know, we have some topics which are relevant from the point of treatment wherein the radiologist intervenes. There are certain stages wherein the surgeon's role comes into the picture, and there are certain places where the medical oncologists have to play a role. So with this few exciting topics, I feel that the program would be definitely be so much exciting, and a lot of take-home messages we all expect from this beautiful agenda, which has been tailor-made with the allied members about what actually, you know, matters or of clinical importance to the people. So with this, I would like to welcome Dr. Vijay Patil, sir, who is the program director for this whole event. This event, which we call as the Masterclass in Prostate Cancer. So Dr. Vijay Patil sir is a medical oncologist from PT Hindu Hospital Research Center in Mumbai, and sir has extensive experience in this field, and he has been very much instrumental in treating a lot of cancer patients, and he has been also a very vivid researcher, wherein his research work is in on published on various good PubMed index channels. So welcome, Dr. Vijay Patil, sir. And with this, I also request sir to introduce the speakers and then take over the scientific agenda forward. So Dr. Vijay, sir, over to you.
Thank you. Without any further delay, let me invite my dear friend, Dr. Kaustav Talapatra. Dr. Kaustav is a senior radiation oncologist and heads the radiation team in Max Nanavati Hospital, and he's a dear friend. And Kaustav has a lot of experience in treating prostate cancers. So let's hear from Dr. Kaustav the role of radiation in locally advanced T3, T4, N0, M0 prostate cancer. Over to you, to Kaustav.
Can you hear me, Vijay?
Yes, you are audible.
And screen is also seen, right?
Yes.
Yes.
Thank you, Vijay. Thank you for this opportunity. It's nice to interact on a prostate platform, and I thank Vijay for organizing such a lovely meeting on prostate cancer. So without much delay, I will be talking on a very specific subset of prostate cancer, that is radiotherapy in locally advanced T3, T4, N0, M0 prostate cancer. So locally advanced prostate cancer has extended clinically beyond the prostatic capsule. So the definition is its extension beyond the prostatic capsule with invasion of pericapsular tissue, bladder neck, seminal vesicle, but without lymph nodal involvement or distant metastasis. And that's exactly what we are talking about: T3, T4, N0, M0, or PT3, PT4, N0, M0 prostatic cancer. So typically, these kind of cancers can be a high-risk prostate cancer or a very high-risk prostate cancer. The definition of high risk is CT3A or grade group 4 or grade group 5 or PSA more than 20. And very high risk is T3B or T4. Primary Gleason pattern is 5, 2 or 3 high risk features, which we defined earlier, or more than 4 cores with grade group 4. So this is what we talked about. This is the high risk and this is the very high risk. T3 and T4 we have already defined. T3 is extraprostatic extension, T3A. T3B is involvement of seminal vesicles, and T4 is fixed or invasion into the adjacent structures other than seminal vesicles. Previously, there used to be a category called T4A, which was invasion into the bladder neck, but now T4 is for all comers. So if we go through the NCCN treatment paradigm, we see for the high risk and very high risk population, apart from other treatment modalities like RP and PLND, external beam radiotherapy in combination with androgen deprivation therapy forms category 1 of evidence. That is when you have a survival more than 5 years or patient is symptomatic. Similarly, if you add brachytherapy based on one randomized trial and few other studies, if you add brachytherapy to external beam radiotherapy and androgen deprivation therapy, that is also category 1 of evidence. And recently, for very high risk group only, addition of docetaxel or abiraterone, which I am sure the later talks and the panels will have a mention in, is also a level 1 evidence of treatment. So when did the role of radiation therapy get established in the treatment paradigm of prostate cancer? This was 2 large trials, basically intergroup trial and the SPCG7 trial, which compared ADT versus ADT and radiotherapy. And there was a significant benefit, the additional of almost 10% survival benefit in the arm which received radiotherapy along with hormone therapy or androgen deprivation therapy. So that was the era when 70 gray of radiation dose was being delivered, and various groups, the European and the American groups, thought, including the MD Anderson group, is there a benefit of dose escalation? And that is around that time, maybe 2 decades ago, 1.5 to 2 decades ago, where a lot of dose escalation studies happened, which escalated doses from 70 gray to a tune of 74 to 78 gray. And most of these studies showed that there was a statistically significant improvement in a biochemical failure-free survival with escalation of radiation dose. However, there was no improvement in overall survival in most of these studies. We also have to remember that most of these studies, because of the availability of current techniques available in those days, that was 4-field box conventional technique or 3D conformal technique, those were the type of techniques which were used, and the arms which had higher doses had also higher rectal bleeding. Basically, GI toxicity of grade 3 or more were higher in those arms. Then came in the era of hypofractionation. I will not get into the radiobiology of prostate because that's a topic in itself, but prostate is, the alpha by beta of prostate is reasonably lower as compared to alpha by beta of head and neck or various others acutely reacting tissue. So taking this differential advantage, prostate was a site where hypofractionation. What is hypofractionation? Same biological dose equivalent being delivered in a much smaller number of fractions, where the fraction size was much higher as compared to the conventional fraction. So in conventional fraction, if people were delivering 2 gray per fraction, in hypofractionation, people were delivering anywhere between 3 to 4 gray per fraction. And then the hypofractionation era came in, which is around a decade to 1.5 decades back. Various studies, Chip, MD Anderson, Hypro, RTOG 0415, among which the CHIP trial and the Hypro trial had, especially the Hypro trial, had significant proportion of high-risk patients. And in most of these trials, the biochemical progression-free survival at 5 years was better with a hypofractionated regime, or at least equivalent with a hypofractionated regime as compared to the standard of care, which was standard fraction of radiation, which used to be delivered over even with that body radiotherapy. This is the internal standard of care.
Seems there is some network issues.
I think there was some
Yeah.
Hello.
Yeah, Dr.
Yeah.
You can start sharing the screen, sir. Actually, your network bandwidth seems
I have shared the screen.
it's not yet visible.
Hello, Kaustav. We can't see your slides.
Okay, I'll share again 1 second. I'll share again.
Technical team, can you help Kaustav to share the slides again?
Yes. He will be sharing, but there is an issue with.
Hello.
Yes, sir.
Yeah. Can the technical team help Dr.
Yes.
Kaustav?
He's having some technical issues, sir. From
I think Dr. Kaustav can rejoin, then that should be,
yes.
I suppose,
That's what,
would be
sir.
solving the issue.
So, no problem. Okay, sir. So, Dr. Kostov is joining from his mobile, and I'm sending Nirav to you the slide. Kindly share from your end.
Okay.
Has someone called Dr. Has someone called Dr. Kaustav?
Yes. We are doing, sir. We are doing.
Sir, I have already speak, sir. We have already sir Saurabh here. Yeah, he's joining in mobile.
Okay. Saurabh, I have joined from my laptop. Can you just make that laptop join as a panelist so that I'll go? Yeah.
Yes, sir. Done.
Nirav, did you get the presentations of Dr. Kaustav Tolapatra?
No. Where you sent, sir?
Email.
on email.
Hello, can you hear me?
Yes, sir. Yes, sir.
Yes,
No,
sir, yes.
There's an echo which is coming. I suppose there might be two devices which would be having the meeting on. So one device you can mute, Dr. Kaushal.
No, I'm trying through this only. If I don't get through, then we will.
Yeah, now it is clear. The audio is clear.
Is the audio better now?
Yes.
Can you
Saroji,
see
I'm
my
posting-
screen now?
No, screen is
Still
not.
not, sir.
Screen is not.
There's one more request for technical team.
Now,
There are
screen?
multiple messages coming that the login is not working. Can they help out with the login?
Yes, sir.
Login is not
I
working.
also got my messages from resident. They have registered, but they have not received the links.
Because I got message from Hinduja team also that they are not able to join because the login is not there.
Sir, it is already shared, sir. Ajay Singh, Dr. Ajay Singh has already talked to me.
Hello, Neerav.
Yes, sir. Saroji, I will send you my mail ID in the chat. If you can immediately share the.
Dr. Kaushal, should I share?
Dr. Kostub, can you see the screen?
Yeah, the screen is visible.
Just he wants to tell me this at what slide he has just got stuck.
Neerav, can you hear me now?
Sir, I
Yes,
can
we
hear
can
you.
hear you.
Yes, I can hear you, sir. Just let me know on which slide you got stuck.
Now, Neerav, if I get stuck here, listen to me carefully. If I get stuck here,
Sir, can you hear me?
hello, Neerav.
Yes, I can hear you, sir. Please.
No, Neerav, I'm logging in through my mobile. Please
Yes,
give me a faculty joining link is what I'm requesting, okay?
Sure, I'll share you on WhatsApp, sir.
Yeah, please, you're trying to join.
Yes, I'll share you on WhatsApp, sir. I'll share you on WhatsApp.
Yeah, hello.
Yes, sir.
Yeah, Neerav, you can share the screen now. You can share the screen.
Just let me know, sir, on which slide.
Yeah. You can go down, please. Go down. Go down. Yeah. The previous one. Yeah, that's all. So these are the common, sorry for the glitch. These are the common side effects, acute side effects and late toxicities I have enlisted. Next slide, please. So as I have mentioned earlier, the previous radiation, those era, we were using 3D conformal radiation, but with the advent of toxicities, with the advent of technology and the radiation oncology community moving on from 3D conformal radiation to IMRT, that is intensity modulated radiotherapy, and eventually IGRT, image guided radiotherapy, the probability and the actual occurrence of grade 2 and grade 3 acute GI and GU toxicities significantly came down, and that has been shown in various studies, including RTOG 0126. Next slide, please. Image-guided radiotherapy is an essential component which, when added to IMRT, allowed better treatment on account of daily changes of target anatomy and positioning, and to account for the daily variations which prostate cancer had, which previous treatment techniques could not ascertain. So recently, next slide, please. There is a meta-analysis published, that is the role of image-guided radiotherapy in prostatic cancer, a systematic review and meta-analysis, and with scored treatment with image-guided radiotherapy scored in almost all features, include over non-image-guided based treatment, including 5-year overall survival, second cancer mortality, biochemical relapse-free survival. So image-guided radiotherapy has almost become the essential in the treatment of prostate cancer. Next slide, please. These are the technical consideration. Prostate is an interplay of structures between rectum and bladder, and then between there is a prostatic urethra passing through. So as I was talking about the techniques, IMRT, IGRT, this is how the dose maps are produced, and this is how you spare dose to the rectum and bladder, delivering high dose envelope to the prostate gland. Next slide, please. The question again was in high risk and very high risk, where the chances of lymph nodal metastasis is very high, whether to do prostate alone or whole pelvic radiation. Till now, up to 5 years ago, most of the studies, including RTOG 9413, has shown that there was no additional benefit of adding whole pelvic radiotherapy. When I say whole pelvic radiotherapy, that is inclusion of your external and internal iliacs and the periprostatic nodal stations. So there was no benefit of adding whole pelvic radiotherapy. Next slide, please. However, the trial from Tata Memorial Hospital showed that in high-risk patients, which a higher propensity of lymph nodal metastasis, addition of whole pelvic radiotherapy did better than prostate alone radiotherapy. So the randomization was 1:1, that is prostate alone radiotherapy versus whole pelvic radiotherapy. Next slide, please. And addition of whole pelvic radiotherapy showed a biochemical relapse-free survival of 95% as compared to prostate alone radiotherapy, which was only 81.2%. Next slide, please. Role of brachytherapy. Peter Hoskins trial, this is a very important study, has shown that addition of brachytherapy boost, even in the high-risk setting, has improve the relapse-free survival over doing external beam radiotherapy alone. And that's when brachy boost also, I'm not saying those escalated with external beam radiotherapy is inferior. There is enough evidence now that doing treatment with external beam radiotherapy alone to a high dose equivalent, which we have talked before, itself is a level 1 treatment evidence. However, addition of brachy boost is also a level 1 treatment evidence in carefully selected patient. Next slide, please. So these were the results of the brachytherapy trial. Next slide. So this is a very nice diagram of which treatment modality and which fractionation schedule to be used in which from the gamut of very low risk to very high risk prostate cancer. And as you see in our subgroup, that is high risk and very high risk prostate cancer, moderate hypofractionation, which we have talked about, and conventional fractionation, both are valid schedules. Next slide, please. Role of ADT in combination of with external beam radiotherapy in high-risk prostate cancer. There are trials, that is the BOLA studies, the RTOG 8610, and all of them have showed that ADT improves all endpoints, including overall survival, except for the RTOG 8610, which has not shown an improvement in overall survival. But adding ADT to external beam radiotherapy in this setting is a standard of care. Next slide, please. Optimal duration of ADT, to cut the long story short, a longer duration of ADT of at least 2 to 3 years as compared to 4 to 6 months has shown to be beneficial in high-risk prostate cancer. So in high-risk prostate cancer, at least ADT schedule of 2 to 3 years should be planned for the patient as compared to a short course ADT. Next slide, please. Now, few words about adjuvant and salvage radiotherapy. After a surgery has been done, you can be a PT3 or a PT through prostate cancer based on the high-risk features such as extraprostatic extension, seminal vesicle involvement, or cut margin positivity. So adjuvant radiotherapy is start radiation upfront based on the pathological features before any evidence of biochemical progression. Salvage is starting the radiation after evidence of biochemical progression or clinical disease progression. And early salvage radiotherapy, which we have been discussing of late a lot, is radiotherapy based on early signs of biochemical progression, preferably before the PSA reaches 0.2 ng per ml. Next slides, please. Next. So, where did the adjuvant radiotherapy come in? These are the 3 large randomized trials: EORTC 22911, SWOG 8794, and ARO 9602, where all 3 of these trials showed that there was benefit. Next slide, please. There was benefit, including overall survival, with addition of adjuvant radiotherapy based on the high-risk features in all these 3 randomized trials. Next slide, please. But still the world thought that just based on high-risk features, all of them will not fail, and we are doing radiation in 100% of the patients who have high-risk feature. Is there a better group to select in whom you can spare radiation? And that's when the concept of early salvage radiotherapy came in. That is, you salvage them early if there is a biochemical progression, and no need to radiate the patients in whom there is no biochemical progression. And the cutoff PSA was kept in most of the studies as 0.2 ng per ml, except for one study, which was 0.1 ng per ml or 3 consecutive PSA writes. Next slide, please. So they were the radicals, Getug and Raves, of which the radicals and the Raves were most established trial, and Getug had to prematurely close. However, we have the pooled analysis of all the 3 studies. Next slide, please. So this is the artistic meta-analysis, which included all the 3 radicals, Raves and Getug trial. Next slide. And these 3 studies, the pooled analysis, showed that the event-free survival actually favored, and with an absolute difference of 1% over 5 years, to the early salvage as compared to adjuvant radiation therapy. And that's from where it started getting established that don't do radiation to all comers just based on 1 or 2 high-risk features. If there is an early progression of PSA, you can always act at that time, and that's when the concept of early salvage came in. Next slide, please. Next slide, please. ADT with salvage radiotherapy. Of course, most of the studies have shown a benefit of ADT with salvage radiotherapy. Next, please. So where do we stand in early salvage? Early salvage needs to start early. That is the concept. Don't start very late. Imaging verification of recurrences is not recommended, and discuss ART if the patient's compliance is in doubt. Next, and the concluding slide, please. So what we have learned so far is there is level 1 evidence to support the use of radiotherapy and androgen deprivation therapy for treatment of locally advanced prostate cancer. Moderate hypofractionation has become the standard of care in such settings. Modern techniques have significantly reduced toxicities, and in post-prostatectomy setting, in well-selected patient, early salvage radiotherapy can be offered instead of offering blanket adjuvant radiotherapy to all patients with high-risk prostate cancer. Thank you.
Thank you, Gustav, for that. Yeah. So because of lack of time, we won't take any questions. And if anyone has questions, can be put in the Q&A section or the chat box. And I am sure Gustav would be happy to answer them directly. So with that, we move to the surgical management of prostate cancer. And I'll invite Dr. Mohammad Ismail Akhtar for this discussion. He's an MCH urologist and is a senior consultant with Kokilaben Dhirubhai Ambani Hospital in Mumbai. Over to you, Dr. Akhtar.
Yeah, so good evening, friends. And to begin with, I'll first apologize because of being late. Actually, what happened, like I also had a problem with my laptop, so there was a technical glitch. So before I begin, I'll start with apology. So this is not the best presentation what I have. Like the laptop crashed around 45 minutes back. So while Costa was speaking, I could arrange few slides. So just let me share my screen. So is my screen visible?
Yes, sir. Just put it full screen.
Your screen is visible and you're audible, sir.
So what I'm doing is I'm trying to talk about few things about radical surgery when we discuss about when we're talking about locally advanced prostate cancer. When we say locally advanced prostate cancer, one need to understand what we are dealing with. Is it the only prostate cancer which has gone outside the prostate, like stage 3 disease or stage 3-4 disease, or something else also? If you see, there are different definitions of locally advanced prostate cancer. It is not only T3, where the tumor has just gone outside the capsule of the prostate and involved either seminal vesicle or base of the bladder or extra prostatic fat. There are different guidelines. There are different definitions by the different societies. If you see, other than locally advanced prostate cancer, other than T3, T4 disease or clinically or radiologically positive lymph node, few definitions also include localized prostate cancer, which are either high risk or very high risk prostate cancer. Why have they included these patients? Though by definition they are localized, they are confined to the prostate, but still we are discussing with a locally advanced prostate cancer because they behave in a manner like a locally advanced prostate cancer, where they have a high risk of biochemical relapse, they have a high risk of having lymph node metastasis. That's why when we discuss locally advanced cancer, we must include patients who have high risk or very high risk localized prostate cancer. But then yes, it doesn't include distant metastatic disease. So before beginning with surgical management of locally advanced prostate cancer, I would like to say that like when we operate a patient, considering that probably we are dealing with a localized prostate cancer disease, a small subset of a population, they may have actually locally advanced disease, T3 disease. And similarly, when we operate a patient who we clinically suspect that probably we're dealing with a locally advanced or a clinical T3 disease, and when we actually do surgery, we will be surprised to see that like it was actually a localized prostate cancer disease. This happened to me last week only when I operated a gentleman whom I thought it's a CT3 disease, but it turned out to be T2 disease. No standard treatment can be defined because we don't have a level 1 evidence as far as what should be the best treatment for patients with locally advanced prostate cancer. A local treatment combined with a systemic one provides the best outcome. However, in 30% of the patient or 1/3 of the patient, only local therapy may be sufficient. So we need to find these patients who may be benefited with adjuvant therapy. Not each and every patient should be subjected to adjuvant therapy. Currently, there are two treatment options available for locally advanced prostate cancer disease. First thing is either a surgery, which is radical prostatectomy along with pelvic lymph node dissection, or radiotherapy along with androgen deprivation therapy. But the optimal treatment is still controversial. Traditionally, radical prostate is not routinely used for the management of locally advanced prostate cancer disease. This is basically because we found over a period of time that only RP may not be sufficient in treating all the patients with locally advanced prostate cancer disease. Although with now we know that like before planning any treatment, we risk stratify patients, and then once we see that the patient is highly falls in high risk category, we know that like patient may need some adjuvant therapy. Also, over a period of time, the radiotherapy advancement has happened, which Costa was discussing about, and we have realized that combined modality of treatment like radiotherapy along with androgen deprivation therapy improves outcome compared with monotherapy, that is surgery. So that's why traditionally it wasn't very routinely used. Nevertheless, we have found that RP can cure some high-risk cases, and addition of adjuvant or combined therapy may further improve outcomes of surgery alone. In recent years, there is a renewed interest in surgery for locally advanced prostate cancer disease. It has been said that one should offer radical prostatectomy to a patient where tumor is not fixed to the pelvic wall, or there is no invasion of urethral sphincter, here in such cases, RP seems to be the favorable or feasible first step in selected patients who have low volume locally advanced prostate cancer disease. In all such patients, extended pelvic lymph node therapy, lymph node dissection should be performed. RP, to my mind, has an advantage of more accurate disease staging with fewer bowel and rectal problems compared to radiotherapy. While yes, there is a risk of anesthesia, there is a risk of hospital stay, there is a risk of blood loss and associated high risk of impotency and incontinence as compared to the radiotherapy. And we also know that the radiotherapy along with androgen deprivation therapy does not require hospitalization, is marginally cheaper than surgery, have a low risk of incontinence, but does not convey a higher rate of, but then it also has some set of complications like radiation cystitis, radiation to bowel, and some possible effects of androgen deprivation therapy. So when we say, when we look into the history of surgery for locally advanced prostate cancer disease, there are few papers which says surgery for locally advanced disease as a part of multimodality treatment have been reported since ages. And with multimodal treatment, we have seen that it offers decent cancer-specific survival and overall survival. These number and these studies have been performed in pre-surgery clinically untreated nodal disease or a metastatic disease. That was like, I would say it was a pre-MRI era. So, and all these studies were retrospective. So, like, is it old now? Should these studies be considered considered while making a decision? Let's go through few other slides and we can come to conclusion. Whenever a surgeon thinks of doing the surgery for a locally advanced prostate cancer disease, first, like the moment he sees the patient, there's a fear in the surgical society, fear of having positive surgical margin, fear of doing probably an incomplete surgery where he feels that probably has not done a decent job and the surgery is not very radical. But then now we know that like we have a decent imaging techniques and which gives a very excellent idea about the amount of bulk of the disease. And also when a surgeon is thinking about doing a surgery, he knows that like he's probably going to be more radical, and probably that's why he's more worried about complications like incontinence and impotency. So when we are planning surgery, it is very mandatory to have decent imaging. Multiple MRI is increasingly used either in the pre-biopsy setting or a pre-surgery setting when we are evaluating patient with prostate cancer disease. We all know that Pirate score, especially version 2, is very much correlated to, like, it's very much it's very good predictive. It has a very good predictive value. However, when we discuss about the local staging, it's still limited. Like, that's why I started with one of a few slides where we think probably we're dealing with a locally prostate cancer disease, and actual prostate biopsy would show that it was a localized disease. And sometimes where we think that probably we're dealing with a localized disease, and it turns out to be T3 or T4 disease. T3 disease, I would say. There are two studies which says that when it comes to detecting malignancy, MRI imaging is very sensitive, but then when it's about detecting either a T3 disease or it's not very, like, the sensitivity and the specificity is very low. It's not up to the, it's not very great. Let's see a scenario. Suppose if a surgeon has posted a patient, considering that the patient has clinically N0 disease, but then intraoperatively found that lymph nodes are positive. So there are a number of studies which favors that, like, one should go ahead with completing the radical prostatectomy rather than abandoning the patient. Results of RP is superior, results in superior survival of patient with lymph node disease after, like, once you know that the complete lymph node mass has been taken care of. That's why even when we come across enlarged lymph node during the surgery, frozen sections are no longer recommended. So when you're considering going ahead with surgery in a so-called clinically N0 disease, but then actually patient has lymph node disease, the same rationale can be used when you see a patient who is locally advanced, who has a locally advanced disease. When we talk of complication, there are a good number of studies which says the continence rates as well as erectile dysfunction rate in a patients who undergo surgery for T3 disease is almost same. Yeah, whenever you're considering surgery, it is very essential to assess the patients, to assess the risk of the cancer. Risk assessment is the ability to assess pathological stage, and it helps in better counseling of the patient. You know that, like, if you see a patient who has got locally advanced disease, or a patient who has a localized disease but a high risk group, you know that this patient is going to either come back with a recurrence, or he may need adjuvant therapy. So it is very important, like, when you counsel the patient, you may tell them that he may end up needing adjuvant therapy. It also helps in selecting the most appropriate therapy for that patient, and if you identify such patients, if at all there is any clinical trials going, then only you can include these patients in such trials. So what are the most important predicting factors or prognostic factors when a patient undergoes radical prostatectomy? It's Gleason score, surgical margin status, and the presence of extracapsular extension or involvement of seminal vesicle or lymph node involvement. So what are the views of pelvic lymph node dissection when you're doing surgery for a locally advanced prostate cancer disease? Does it have a diagnostic value, or it is also therapeutic? And what should be the extent of lymph node dissection, whether it is to be standard or extended or super extended lymph node dissections? So as per EA recommendation, all the patients who have locally advanced prostate cancer disease, in such patients, one should do extended pelvic lymph node dissection. It has a diagnostic value and a prognostic value, but then it does not have any therapeutic advantage. Extended lymph node dissection includes the removal of nodes overlying the external iliac artery and vein, nodes within the obturator fossa, both cranially and caudal to the obturator nerve, and nodes medial and lateral to the internal iliac artery. If you find any enlarged lymph node, adding common iliac area and presacral area further increases the clearance. There is no survival advantage, but then yes, one may argue that, like, in patients, those who have microscopic metastasis to this lymph node may get cured or may have some advantage, but then definite oncologic benefit is not available. So there are other studies which says extended pelvic lymphadenopathy does not have any does not improve any oncological outcome or survival. But then yes, it improves, it gives better staging, and hence it has a more of a prognostic value rather than therapeutic value. Same studies, like same, and so when you say extended lymph node dissection, all the three areas should be cleared. So when you see a patient who has got stage 3 disease, when you're considering stage 3 disease, first thing is proper counseling, proper selection of the patient. Is there a role of offering any new adjunct androgen deprivation therapy? No, there is no advantage of doing adding any new adjunct androgen deprivation therapy. Yeah, there are a few trials which are going to they're trying to find if there is any advantage. All patients should have proper imaging, and one should know like what is the bulk of the disease, what is the lymph node status, whether the disease is involving any adjacent organ like rectum or ureter. During surgery, it has to be tailored approach based on the imaging, and one should try and do as much as radical procedure as possible. And the extent of lymph node dissection, as discussed earlier, has to be extended pelvic lymph node dissection. As far as post-op radiotherapy or androgen deprivation therapy is concerned, I think Kaustov has covered, and other speakers are going to cover androgen deprivation therapy. So I'm not going into the details of those therapy. Same like role of adjuvant therapy. So to my mind, when we talk of radical prostate surgery, around 1/3 patients with locally advanced prostate cancer disease, they may become cancer-free, and they may remain cancer-free even at the end of 8 to 10 years, despite knowing that they had clinically advanced disease. So it's not half, it's at least 1/3 of the patients. Other advantage of radical prostatectomy, it provides exact pathological stage. It tells us proper grade, because there may be grade migration, there may be stage migration from biopsy report and from radical prostatectomy specimen. And it also gives exact and detailed or precise idea about surgical margin status. This accurate and precise pathological staging can identify patients who are at risk of recurrence and can be subsequently managed by other combination therapy, either in the form of hormone therapy or in the form of radiotherapy. So that's, to my mind, is a very big advantage of robotic prostatectomy, radical prostatectomy. So what are the guidelines has to say? So almost every guideline supports patients, like in selected patients. Not every patient would be candidate for radical prostatectomy. Is those patients who have low volume disease but the locally advanced disease, their radical prostatectomy can be performed along with extended pelvic lymphadenectomy. But then it is very important that the patient needs to be informed that that they may need multimodal approach post-operatively. So the approach should be individualized as per the stage of the patient, as per the comorbidity of the patient, whether the patient can tolerate surgery or not. Surgery offers an effective treatment when used in accordance with clinical parameters and advanced imaging. If used well, we could reduce over treatment with androgen deprivation therapy or radiation therapy and improve outcomes. Monotherapy surgery roughly represents an option in 30% of the patients with high-risk disease who may not need any adjuvant therapy. It is very important to use different tools to reduce the positive surgical margins, and so as to improve the surgical outcome. So surgery is a valid option in experienced and I would say more so in selected cases. Thank you. And I would be very sorry, because like this is what I could manage in the last 45 hours. My actual presentation was something different, where I was quoting more studies, but then I'm sorry for that.
Yeah, thank you, Dr. Akhtar. There are no questions for you. So thanks for the nice quiz talk. We move ahead with the next talk, and I invite Dr. Ajay Kumar Singh. Ajay is a dear colleague and a friend, and he's now an associate professor in Tata Memorial Hospital, and he looks after urological cancers. And let's hear from him what's new in neoadjuvant therapy in prostate cancer. Over to you, Ajay.
Thank you, Vijay sir, and thank you for this opportunity. Is my slides visible and I'm audible?
Yes, sir.
Yes, Ajay. Your slides are visible and you're audible.
Okay, so my talk is regarding role of neoadjuvant therapy in this locally advanced prostate cancer. So coming to the background, so as we all know, the prostate cancer is nowadays very heterogeneous disease, and from treatment point of view, we broadly divide these patients either as a localized disease or locally advanced disease or metastatic disease which may be either hormone sensitive or castrate resistant prostate cancer. And again, in this localized disease, this was again substratified based on the initial D amico risk stratification criteria, and which includes PSA level grading and T stage. And there are other modification of this, but these are the basic factors which we consider while subdividing these patients of localized prostate cancer. And based on this, the patients with the PSA score of more than 20 or Gleason score of 7 and above, or ICP grade 4 and 5, and those who are clinical T2, the T2, or are classified as high risk disease. And after that, irrespective of the PSA level or the Gleason score, those with not positive disease or T3 or T4 disease are classified as a locally advanced disease. And when we look at the outcome of these disease, the patients who are having a localized disease, is the outcome, the long-term 5-year overall survival is in the tune of 90 to 99%. And even at 10 years also, this remains more than 90%. But again, when we look into the subcategories of this risk stratification, the high-risk patients having a poor outcome in terms of the biochemical recurrence or progression, all these outcomes. This is just a basic diagram depicting the what is the this basic model of treating this localized prostate cancer. In low risk patients, the preferred approach is active surveillance. If not possible, then maybe a radiotherapy or radical prostatectomy will be the option. Again, in intermediate, it is again subdivided either favorable or unfavorable. In favorable, we may consider again active surveillance is the preferred one, but in unfavorable one, local therapy, either radical either local radiotherapy or radical prostatectomy will be the option. In high risk, again, active surveillance will be less preferred, and it will require more of a local treatment in the form of either radiotherapy, where we have predominance of the data, and in some candidate, radical prostatectomy will be the option. So now coming to the my current talk regarding neoadjuvant therapy. So as we know, the basic principle of neoadjuvant therapy is shrinkage of the tumor so that the surgery becomes easy, and to control the micrometastasis. And other requirement is to neoadjuvant therapy may improve the oncological outcome in terms of overall survival or progression-free survival, and it may help in prognosis by showing the pathological response rate and some pre-treatment tumor factors, which may help in give some idea clue regarding the prognosis of the tumor. So in prostate cancer, the reasoning for the neoadjuvant therapy is at 10 years, the biochemical relapse is around 30 to 50% in high-risk subgroup patients. And with this, and in this group, whenever there is a biological positive surgical margin, the risk of biochemical recurrence increases. And with this increase of the biochemical recurrence risk, there is an increased chances of using subsequent therapy or adjuvant androgen deprivation therapy. So what are the treatment options available in this neoadjuvant setting? So most commonly it may be androgen deprivation therapy, or maybe it may be chemo hormonal therapy combination, or recently we are now started getting data regarding novel hormonal and plus ADT combination therapy. We will come to each options is one by one. So coming to this androgen therapy. So this was the first retrospective data. We showed that this neoadjuvant therapy, androgen deprivation therapy, given for almost around 3 studies, it may be around 6 months. And when we come to the outcome, so you can see that this primary outcome in terms of clinical downstaging or pathological and disease confinement to the organ or positive margins and seminal vesicle invasion, all these were shown benefit in patients who receive neoadjuvant ADT, and also the pathological this lymph node involvement become less common in patients who receive neoadjuvant ADT. And based on this retrospective data, when the randomized study conducted, again you can see that the long-term outcome like biochemical relapse or PSA progression, local recurrence, or metastatic disease.
Dr. Ajay?
there was sir, actually there was a low bandwidth with Dr. Ajay, so somehow got disconnected.
Sir, he has joined again. Sanjay sir.
Oh, sorry, my apology. I was disconnected.
Dr. Ajay, you can do one thing. You can share the screen again and you can put your video off. Not an issue, sir.
Is it visible?
The slides are visible. Just put it full screen and continue from that slide where you
Yes,
last.
Ajay, it's visible.
So for the when we go to into the data for the ADT and the retrospective data, we can show that all the acute outcomes like downstaging of the tumor, organ confinement, decreasing in the positive margin status, and seminal vesicle invasion and lymph node involvement were in favor of the ADT. But in when we this based on this data, when the randomized studies were conducted, the longer oncological outcome in terms of biochemical relapse or local recurrence, metastatic disease free and overall survival, these have not shown any improvement in patients who receive neoadjuvant ADT, in patients who are in high risk subgroup, patients who are planned for surgery. So for this androgen deprivation therapy, my conclusion is that all the studies who have made their acute oncological outcomes in terms of downstaging of the tumor or reduction in the positive margin or reduction in the nodal positivity rate, but the long term outcome which is more important to the oncological point of view, the overall survival, disease this metastatic free survival or biochemical recurrence was not improved. After this ADT, then there was the chemohormonal data. So there is 3 predominant study. 2 are retrospective nature and 1 is randomized study. The retrospective study has included 177 patients, included again most of the time very high risk patients, locally advanced patients, and they'd given 4 to 6 cycles of gocirelin, bicalutamide, docetaxel every 3 weeks versus only ADT. And ADT, and third arm was the immediate this surgery arm. So again, you can see that in this retrospective analysis, the acute outcome in terms of undetectable PSA or downstaging of the tumor has shown improvement in patients who received neoadjuvant treatment in terms with the chemohormonal regimen. Then there was one more retrospective study in 56 patients who included high-risk patients, clinical T3 or PSA more than 15, and Gleason pattern of 5. Again, they've given complete androgen blockade along with 6 cycles of docetaxel versus immediate RP. Here again, they have shown the biochemical relapse was less common in patients who received chemohormonal therapy as compared to this who patient underwent upfront surgery. And the third one, the randomized study. Again, this is a large study, CalGB 90203. This was the phase 3 randomized study, included 780 patients, and again they included docetaxel for 6 cycles along with the this androgen deprivation therapy versus patients who underwent upfront surgery. And in this study, the primary outcome, the primary endpoint was the 3-year progression, PSA progression-free survival. And other endpoints like lowering of the pathological stage and reduction in margin positivity or nodal positivity and reduction in seminal vesicle involvement was seen significantly in patients who received neoadjuvant chemohormonal therapy. But the primary endpoint of 3-year PSA-free survival was not improved. But when the longer-term data published in 2019 in AU and SU, it has shown that the 8-year biochemical free survival was significantly improved in patients who received neoadjuvant chemohormonal therapy, and the 10-year overall survival again showed a significant improvement from 74 to 80% in patients who received neoadjuvant chemohormonal therapy. And again, that this lead to decrease in the use of adjuvant or salvage treatment after the surgery in patients who received neoadjuvant chemotherapy with a median treatment-free survival of 4.5 years in patients who received chemohormonal therapy versus 1.8 years in patients who received surgery only. So for this chemohormonal, my conclusion is that the data is very limited and it is showing improvement in both short and long-term outcome, but to introduce in clinical practice, we need more consolidation data with more well-designed study, so that neoadjuvant may be included in neoadjuvant chemohormonal therapy may be considered in future in clinical practice. And the last, the novel hormonal therapy combination. So again, there was a retrospective data from MSKCC. They analyzed their data from 3 trials and included patients, 112 patients in neoadjuvant group and 259 patients in who underwent upfront surgery. And the neoadjuvant treatment was basically apalutamide and abiraterone based combination along with ADT. And again, they have shown that the acute outcome like downstaging of the tumor and metastasis-free survival, biochemical PSA biochemical recurrence was less, and again salvage and adjuvant rates were less in patients who received neoadjuvant chemotherapy. And recently, the 2 abstract was presented in 2020 ASCO. The first one is this phase 2 trial of intense androgen deprivation therapy prior to radical prostatectomy in men with high risk localized prostate cancer. And in this, they included patients with prostatic adenoplasma Gleason score of more than 7 and above, PSA of 20, and T3 disease and more, and with pelvic lymph node positive but less than 20 mm. 3 course involved with cancer with minimum of 6 course obtained, and or more than 1 centimeter tumor or T3 disease on MRI with a performance status of 0 to 1. So this was conducted in 2 parts, part 1 and part 2. The part 1 was giving abiraterone apalutamide along with the ADT, loprolide and prednisolone for 6 months, followed by radical surgery. And the another arm was only abiraterone ADT for 6 months, followed by radical prostatectomy. And again, in part 2, these were again put on adjuvant therapy for 1 month with combination of abiraterone, apalutamide, and ADT in both the arms. So primary in the part 1, the primary outcome was this endpoint was the rate of pathological response plus MRD, which means around less than 0.5 mm of tumor left by central review. And in the part 2, the primary endpoint is 3-year biochemical PFS. And when we see the baseline characteristic, you can see that a significant proportion of patient has high risk features, around 50% having Gleason score of 9, and more than 90% patient having high risk of as per the NCCN definition. And when we come to the outcome, the pathological outcome was almost say around 20 PAS CR in 20% patients in both combination of abiraterone and apalutamide, or only this abiraterone and ADT combination. So they have shown a significant, there was no difference in pathological CR, but they have shown there was significant achievement of pathological CR patient who received some neoadjuvant therapy. And the other points also, like positive surgical margins or seminal vesicle invasion, there was no any difference between these 2 groups, but by adding this neoadjuvant treatment, there was an improvement in all these parameters. So from this data, the conclusion was, as most of the patient had received had achieved decline in PSA, so PSA was not able to correlate with the pathological response. And only 11% of the patient had only grade 3 or treatment adverse related events, which were hypertension or elevated ALT, elevated AST, and there was no any 4-5 grade adverse events. And the part 2 of the study, like 3-year biochemical PFS, is still awaited. And this was the second abstract in the ASCO 2020, again showing the combination of apalutamide with ADT and with or without abiraterone in localized high-risk prostate cancer. This was the trial schema with the patients included were adenocarcinoma Gleason scale more than or 8, and those with Gleason score 7 having a clinical T2B disease plus PSA of more than 10 nanogram and absence of metastatic disease. They randomized these patients for neoadjuvant therapy for apalutamide or ADT, or apalutamide abiraterone plus ADT for 6 months. And the primary endpoint, again, the reduction of the tumor and the screen for pre-treatment markers to correlate with the outcome, and residual cancer quantification and PSA recurrence and safety. So they, out of the 65 patients which were enrolled, 63 patients underwent surgery, and 2 patients withdrawal from the consent, so they won't underwent the surgery. And 98% patient had a PSA of less than 0.1, and 40% patient has shown disease was confined to the organ only, and 16% patient who received APL had a complete pathological response, and 10% of patient who received a combination of abiraterone, apalutamide had a complete response. And this difference of was not statistically significant. So this was the outcome data. We can see that the disease confinement rate in both the arms was around 40%, and pathological response was 16% versus 10%, which was not statistically significant. And the almost 100% in the in the apalutamide and ADT arm, and 97% in the abiraterone apalutamide and ADT arm had a PSA level of less than or equal to 0.1. When further analysis of unit analysis of this study showed that patient who had a P10 loss or nuclear ARV7 presence or glucocorticoid receptor positivity more than 10% and Ki67 70%, 10%, they had a persistent cancer in their residual specimen. So from again the conclusion from this study that though this pathological response and other outcome was similar, but they have shown that these adding new adjuvant will lead to improvement in these high risk category patients in terms of achieving a pathological response or reduction in the margin status. And again, these four markers like P10 loss and ARV7 presence and glucocorticoid receptor loading and Ki67 more than 10% was a marker of resistance. And maybe these are the patients who need some alternative approach rather in neoadjuvant therapy. And this is my last data on the novel hormonal combination therapy. This was presented in the last year ASCO annual meeting. Again, this was the phase 2 trial of neoadjuvant ADT plus abiraterone and apalutamide in high risk localized prostate cancer patients. They included a high risk patient who are having more than or equal to 1 factors, in which were PSA more than 20 or Gleason score 8 to 10 and clinical pathological T3 or node positive disease. And these were then they were randomized to either this gosirelin abiraterone combination or adding apalutamide in the another arm, followed by the radical surgery, and they received this therapy for 3 months. And the primary endpoint was the pathological complete response or minimal residual disease of less than 0.5 centimeter, and secondary endpoint was safety, rate of residual cancer burden, and the correlation between the PSMA PET and MR and the biochemical relapse. So here you can see that the residual cancer burden was achieved in most of the around in significant proportion of the patient, around 32% patient who received combination of abiraterone and apalutamide. And they have shown that patient who achieved complete PSMA PET response, they have demonstrated the residual cancer burden of less than 0.5%, 0.25 cubic centimeter in 50% compared to the patient who had not achieved complete PSMA PET response. And the rate of biochemical response relapse was 14% in patient who had a residual cancer burden of less than 0.25 cubic centimeter against the 38% patient who had not achieved the residual burden of 0.25 cubic centimeter. And at median follow-up of 2.5 years, all patients who had a complete PSMA response and residual cancer burden of 0.25 cubic centimeter was free of biochemical relapse. So again, the conclusion from this study was that there was no difference in pathological response or minimal residual disease observed between the arms, either combination of apalutamide, abiraterone or abiraterone ADT arm, but significant portion of patients had achieved a good response. And the pathological complete or minimal residual response after intense ADC was infrequent, and significant proportion of patients who achieved favorable pathologic response had a residual disease burden of less than 0.25 cubic centimeter. And the PSMA PET response was potential surrogate of pathologic response. So from all these data, my take is that at present there is no any standard recommendation regarding neoadjuvant therapy in prostate cancer in any either ESCO or NCCN or ISMO guideline. But in selected patients who are having high risk localized prostate cancer, we can consider 3 to 6 months of ADT or preferably chemohormonal or novel hormonal based ADT combination. And at present, whatever data available, they are showing definite benefit in terms of short-term outcome like downstaging of the tumor and in reduction in surgical margin and nodal positivity. But the long-term outcome in terms of biochemical relapse or progression-free survival, disease-free survival, or this overall survival outcome is not mature in any study, and that needs more and more well-designed study to give further conclusion regarding neoadjuvant chemotherapy. Thank you, everyone.
Thank you, Dr. Ajay. That was a wonderful presentation. And with this, I again welcome Dr. Vijay Patil sir to deliver his talk on adjuvant hormonal targeted therapy in prostate cancer. So, Vijay sir, over to you. You can start your.
Yeah, thank you. So my topic was of adjuvant androgen deprivation therapy, and what I've done is, as a few students there, put it quite simple as to what are the indications, which agent, what dose and duration, adjuvant versus neoadjuvant, and continuous versus intermittent. So let's talk about the first situation. Is adjuvant androgen deprivation therapy required? Now, this is what we have been seeing. This was shown by both the previous speaker, Dr. Kaustav. So I'll tell you the risk classification says very low risk, intermediate, high, and very high. How I do it is, I look at the PSA levels. If it is below 10, then the patient can go actually in any risk. If it is 10 to 20, the patient can go in intermediate, high, or very high. Greater than 20, the patient can go only in high or very high. So first that puts into the frame where the patient would be. Then look at the Gleason score. Gleason scores, which we'll now talk about, talk about the score, we actually talk about grade. That is 1, 2, 3, 4, and 5. One is 3+3 because there are two components in the prostate, primary and secondary, and one each is scored from 1 to 5. So the minimum score you can have is 2, the maximum is 10. So in grade 1, you have 6, grade 5 is 9 or 10. 2 and 3 have 7, and 4 is 8. So if you look carefully here, if you have grade 2, you go directly to intermediate group. Anything above that, grade 4, you can go to the high or very high. So it's very simple for low to very low. It is always will be T1. It will be the least amount of the grade groups, and it will be the least amount of PSA. The high group, it will be PSA more than 20, or a high risk of grade group, or a T3B or a T4 lesion. The rest actually falls in the intermediate group. That's a simple way of remembering this classification. Now, why do we need to remember this classification? Because adjuvant of androgen deprivation therapy is actually dependent on this classification. How do you treat with this classification? Now, how do we know about this adjuvant? So adjuvant is dependent on this classification. It can be very high. If it is very high, we need adjuvant therapy. High group, we need. Intermediate group, we need it if we have unfavorable features. So if you see here, very high, we need to give adjuvant. High, we need to give adjuvant. Intermediate unfavorable, we need to give adjuvants. And intermediate favorable also, we need to give adjuvants. In intermediate unfavorable, if you are going to plan radical prostatectomy, and if the nodes are positive, then you need to give adjuvant. If you plan EBRT, then you need to give adjuvant. In favorable groups, you need to give it in a patient who has undergone radical prostatectomy and it is node positive. You can see I have highlighted RP done and don't negative and EP positive. In this group, you need to give adjuvant if there are any high risk features. If this margin is positive, seminical vesicle is invasion, or your extracapsular extension. Or I'll show you a molecular test which can help us. In low risk, if the patient has a retroperitoneal radical prostatectomy done and any of these are present, then you need to give adjuvant. So adjuvant very high, definitely. High, definitely. Intermediate unfavorable, yes. Intermediate favorable if node positive. Low risk and intermediate favorable if they have high risk features, and you can take help of the deciphered molecular assay. Before the deciphered molecular assay came into picture, we had something called a Scapera-S score, which looked at the scoring for the very high risk features, and if the score went above, how much above? Above 5, then it would used to say that this patient paper require adjuvant hormonal therapy. And you have to score the PSA, seminical vesicles, margin, Gleason, extracapsulation, and LNI. Now, it was seen that even this code didn't help. So they developed a RNA fusion test. It's based on 22 genes. This has got validated. It's called Decipher. How do we interpret this test? This can be done on the prostate specimen or can be done on the biopsy. The scoring for Decipher is between 0 to 1. Anything above 0.6 means high risk, which means the patient needs to be given adjuvant or androgen deprivation therapy. So coming back to indications, very high, definitely will give. High, we will give. Intermediate, unfavorable will give. Intermediate, favorable if node positive will give. Intermediate, favorable if nodes are negative or low risk. We would today do the Decipher analysis, and if the score is above 0.6, we would give the therapy. Now, what agents to give? Now, the agents we need to divide in two groups. One is those patients who have node negative, one who have node positive. In node negative, you would say that orchidectomy I have not put an option because the duration of therapy is small. So you can either give LHRH agonist. Because LHRH agonist can give rise to flare, you can also give it in combination with the first generation anti-androgens. You can also give LHRH antagonist, and we'll see how we select amongst this. LHRH antagonist, or you can even today combine them with abiraterone. Now, how to select will come in the next slide. If you're node positive, orchidectomy is an option, and all these are an options with combination with abiraterone. So let's go how to choose, and let's go how to choose in N0, M0 patients. It's very simple. In N0, M0 patients, you would add abiraterone only if the patient has very high risk features. So what are the things which are going to make the patient very high risk? Very simple. If you have a node negative disease with a T3 or a high risk Gleason feature, or you have seminical vesicles involved, extracapsular extension, then the patient gets abiraterone along with it. Rest all, you can actually take any of these one choices. LHRH agonist, LHRH plus androgen and first generation, or LHRH antagonist. Now, there was a randomized study in which total androgen blockade versus only LHRH was compared. There was no survival benefit, but there was a PSMA failure benefit, and hence many people with LHRH agonist along with radiation would like to combine it with an anti-androgen, basically baccaratone. Now, what about N1, M0? N1, M0, you need to give it for long duration. Mainly, it falls into high-risk features. Now, in this situation, I'll show you the data in the next slide. You need to select these ones, those who have a combination with abiraterone ones. You can select LHRH agonist, LHRH antagonist, orchidectomy, especially if the life expectancy of the patient is below 5 years or he has a lot of comorbidities. But if patient life expectancy is beyond 5 years or has limited comorbidities, then selection with abiraterone seems to be a better choice. And why is that? This is based on a Lancet analysis which came a year back. There were two trials. The Stampede has multiple trials. There were two trials, one called abiraterone trial, which randomized patients to ADT alone or ADT with abiraterone. The second trial was abiraterone enzalutamide trial, which randomized to ADT alone or a combination of abiraterone plus enzalutamide. Local RT was given in 85% of the situation, so it is in the situation which we are talking, and both the studies at the same endpoint. What you could see is across all the status, you could see that there was a benefit of giving combination chemotherapy. Combination androgen deprivation therapy, which was combination of the LHRH with abiraterone. And this also turned out to have overall survival benefit with a healthy hazard ratio of 0.6. And hence, they concluded that abiraterone acetate with prednisolone, along with LHRH, in high-risk non-metastatic prostate cancer is the new standard of care. Now, the question can also be asked, why not abiraterone plus enzalutamide? The reason being, this therapy needs to be given for long duration, like 3 years. Abiraterone and enzalutamide had 57% adverse events. And hence, it was not taken as a choice because the other agents had adverse events in the range of 20 to 30%. So at present, in very high-risk patients, LHRH with abiraterone is the treatment of choice. Now, whether it would be LHRH agonist or antagonist, how do we choose? Now, frankly, there is quite a few analysis which show that these both are non-inferior, which means that both are similar to each other. Now, when you give LHRH agonist, because of the agonist activity, testosterone level actually increases and then it decreases after 14 days. And that is the reason why in combined androgen blockade, many times for the first 14 days, paclitaxel is given. As opposed to that, you do occult active nature, the testosterone falls immediately. Now, this increment in the value of testosterone can actually lead to something called as flare phenomena, which is reported in literature from as low as 4% to as high as 63%. Now, in normal circumstances, this won't have any issues. But if the patient has a symptomatic prostate cancer, which patient is symptomatic because of local disease burden, has obstructive voiding symptoms, or has spinal cord met, this can be difficult. So this is the situation in which you would want to prefer a LHRH antagonist. Cardiovascular impact. A lot has been written about the cardiovascular safety of degarelix, and it has been seen both in randomized studies and the real world data. That is, to some extent, this is true. It decreases the risk of cardiovascular side effects. So if a patient has a lot of cardiovascular comorbidities, the agent of choice will be degarelix. So just to confirm, agent, how you would select it? It would be an LHRH agonist or an antagonist. If there is a risk of flare phenomena or a cardiovascular, it will be an antagonist. Would you add combined androgen blockade? Yes, you would add combined androgen blockade, especially if you are using LHRH agonist, especially in node positive cases. In very high risk group, you would also consider adding abiraterone in this basis. To simplify, in intermediate risk group, you can get away with giving only LHRH agonist or LHRH antagonist. If you go agonist, go with a combined androgen blockade. If you go for a high risk group, in the high risk group, you can get away with giving only a LHRH agonist or LHRH antagonist. But in the very high risk group, or especially those who have node positive disease, addition of abiraterone has both a DFS and a overall survival benefit. Now, the next question is, we know when do we want to give it? What agents want to give it? The next question is dose and duration. Now, in intermediate risk group, the dose and duration of adjuvant is for 4 to 6 months. In high to very high risk, it's between 2 to 3 years. Normally, people in high risk would like to give up to 2 to 2.5 years. In very high risk, it will go up to 3 years. Now, on what basis is this been based on? This is based on multiple studies, and fortunately, we are conducting this in March, and hence we could quote this paper which came in Lancet and in February 2022, and it's an androgen deprivation therapy and looking at the various ways of giving androgen deprivation therapies. What it shows is, when you give long-term period of androgen depression, 13 to 36 months versus 2 to 6%, there is a improvement in metastasis-free survival, and the absolute benefit is 7.7%. Similarly, for a longer duration, the absolute benefit in terms of overall survival is 5.6%. And this is irrespective of the risk group, patient age, and radiotherapy dose. And on the basis of this, most of the people would want to give in high risk and very high risk group a long duration of treatment. Has there been a study of, in the high risk group, how long? Whether 36 months or 18 months, 2 to 3 years, so 1.5 years versus 3 years. So it was this randomized study, which was a long randomized study, and it recruited good amount of patients, around 600 patients. What it shows is the 5-year overall survival was 91% with the long arm and 86% with the short arm. This P was 0.007, very close to statistical significance, but didn't reach statistical significance. And hence, they actually concluded that 18 months can replace 36 months. We need to understand this was not a non-inferiority study, and so this conclusion is not based on the evidence. So at present, if your patient takes quality of life, because if you give long duration of ADT, quality of life is an issue as an concern, then 18 months is the way you can give, or else 36 months, that is 3 years, the way classical RTOG studies done is the way to give androgen deprivation therapy. Now, neoadjuvant to be given or adjuvant to be given. Now, this was another study, and this again came very recently. This came in this month's edition of JCO. And this is a pooled analysis of 12 randomized studies. And it is clear that across board, when you're giving it with both metastasis-free survival, distant meds, cancer-specific mortality, and OS is better with adjuvant hormonal therapy. The reason being, most of the time, neoadjuvant is being given only for a limited period of 4 to 6 months, at the most 8 months. So, and we all know that longer the therapy, more the benefit it comes. And so, this is more than neoadjuvant adjuvant. This seems to be a function of the duration of adjuvant therapy. Just to show you that across all the adjuvant actually benefits. Now, there's an interesting question. If you want to give for high risk and low risk for 3 years, do you want to give continuous or you want to give intermittent? Like give it for 6 months, you block for 1-2 months, and then again give it for 6 months block of 1-2 months. And that will help to recover the testosterone function. There are multiple studies which have done it, and even in locally advanced setting, most of them are in the metastatic setting, and this always has been diluted with patients taken from metastatic setting. So there is not much evidence per se for intermittent in a locally advanced setting, but on the basis of this evidence, it seems to be safe. So what we can conclude on androgen deprivation therapy? What are the indications? A high-risk patient, a very high-risk patient, an intermediate patient with unfavorable risk factors, an intermediate patient which has favorable risk factors but has a node-positive disease, a low-risk patient which has high-risk features like extracapsular extension, margin positivity, perineural invasion, high Gleason scores, a high PSA after surgery. You can do molecular testing in intermediate favorable group and in the low-risk group called decipher assay. It's a 22 gene RNA fusion test. If your score is above 0.6, this requires androgen therapy. What should be the agent? It's very simple. If it is node negative, LHRH agonist, LHRH antagonist are good enough. If it's node positive, LHRH agonist or LHRH antagonist are required, and preferably addition of epitrol. What should be the duration? If it is intermediate risk, a duration of up to 6 months is okay. If it is high risk or very high risk, a duration of 3 years is 2 to 3 years is considered sufficient. If the patient has issues with quality of life, at least a duration of 18 months. If a patient has issues with quality of life, a stop and break schedule also can be used in this. With that, I'll stop. If there are any questions, I would be happy to take.
Thank you, Dr. Vijay. That was an excellent talk, and you very clearly shared your views about the way we should approach a patient. So, with this, I suppose we end the first part of this scientific agenda. So, I would now request you to invite our moderator for the panel discussion, and then begin the next part. Over to you, Dr. Vijay.
Okay, over. So, I'm very happy to invite my senior from Tata Memorial Hospital, or actually a grand senior from Tata Memorial Hospital. I'm the lion and doyen of Bhubaneswar, Dr. Ghanshyam Biswas ji. Okay, welcome, sir. And I'll take the pleasure to invite his panelist, Dr. Tamojit Chaudhary ji, the senior consultant head of Department of Medical Oncology from Tata Memorial Hospital, Jamshedpur. Dr. Balchandra Kashyap ji, senior uro-oncosurgeon from Jahangir Hospital, Pune, and Dr. Subrakanti Kundu ji, and senior faculty member from Apex Hospital, Jamshedpur. And I think all your panelists, I could see Balchandra ji and Tamojit ji. I'm not able to see Dr. Kundu. Dr. Kundu is online?
Dr. Kundu will join shortly.
Okay. So I would request you to inform Dr. Biswas as soon as he joins. Over to you, Dr. Biswas. Go ahead.
Thank you, Vijay, for that kind introduction. So welcome to private practice. So welcome to outside the world of TMH. So
Dr. Ghanshyam, just put it full screen.
That's fine?
Yes, perfect, sir.
Okay. So clinical situations, so medical oncologist, surgeon, and radiation. So I have two cases. So from my practice. So before we grace the gentleman gracing the disease of gentleman, we can say. So the biggest enemy of a gentleman is a prostate cancer. And so whatever we have done to these patients, so these are situations where we many a times you may not be adhering to the guidelines, but yeah, in real world something happens which may not be in the guidelines. But yeah, so let us now see so how the prostate cancer disease progression happens. So it can happen with a non-metastatic hormone sensitive prostate cancer, which is a localized disease. And 5 to 25% of the new prostate cancer diagnosis will present with a de novo hormone sensitive prostate cancer.
Ghanshyamji, just sorry for the interruption. Ajay has also kindly agreed to be a panelist. So I would require Ajay, if you can also start your video. Ajay is a dear colleague and a professor, assistant professor in medical oncology in Tata Memorial Hospital.
Right. So
I'm joined.
Okay, so Ajay is traveling seems. So the third is 10 to 20% of men diagnosed with prostate cancer developed CRPC with approximately 5 years of follow-up. Majority of the patients with MCRPC progress from a non-metastatic CRPC, and you know that the importance of this group is actually happening much. So that's why I put one case in this group. So 1/3 of non-metastatic CRPC cases progresses to MCRPC within 2 years. And after progression, we know that the all-cause mortality increases, complication related to metastasis happens. So a retired postmaster from West Bengal, 79 years. So this last November 2022. So he usually goes for an annual health checkup, but 3 years of COVID probably did not allow him to do that. So just post-COVID, so he went for a routine evaluation, investigations, you can say, to a private or a corporate hospital nearby. So no comorbidities, no addiction, no positive family history of malignancy. He has only undergone a knee replacement in 2018 for a bothering osteoarthritis. And suddenly the next day after the blood reports, PSA which came high, ultrasound showing enlarged prostate with a high residual urine. And he was absolutely asymptomatic for that. So these are the PSA, so which were done on 2 different labs, 125 and 128. And if you see the November 2022 ultrasound, so it is a significant residual urine with a prostate measures of 49.4 into 40 into 47.8, and the prostate weigh about 49.7 gram. And so that was the report that was available for a routine executive health checkup, you can say. Then they meet a nearby urologist who guides them for a TRUS that was done on 3rd December. And you can see the report: invasive acinar adenocarcinoma, Gleason score of 4 + 5, 9 out of 10, WHO grade 5, tumor load in all cores, 80%, perinuclear invasion present. So that's then they came to me from Kolkata to here. You can see the PSMA report that was in early January this year only. Prostate enlargement showing a PSMA uptake in the posterior lobe, right more than the left. The lesion involves the bilateral seminal vesicles and aborts the rectum posteriorly. So the important here is bilateral seminal vesicles and the rectum. Unfortunately, for a asymptomatic gentleman, you can see there's a right common iliac where it is significant SUV uptake, and the left internal iliac with a significant uptake is there, and rest absolutely normal. So we'll start from our surgical colleague. So this is the PET scan. So how do you stage? So how do you re-stratify this patient?
He is locally advanced, high risk. You could stage him based on the findings at clinical T3B N1 N2 N1/N2 MX, or if you take nodes as positive, these are mainly regional nodes, so it could be N2, but MX, no skeletal mets.
Okay, so Dr. Tamajit, so do you differ from Dr. Balchandraji?
Good evening, sir. Good evening.
Good
So
evening.
yeah, so it's a seminal vesicle involvement. So T3B disease, there is no doubt, and I believe all are regional nodes. So it will be N1, and PSMA PET CT not showing any non-regional nodes or other visceral or bone mets. So it will be M0. And according to risk stratification, it will be either very high risk or you can say it as per recent NCS in regional risk group also, because all N1 disease is classified as regional risk groups.
Ajay, so do you want to anything add to this?
Sir, for me, yes, T3 is the T stage is a T3B, but I'm just confused regarding the nodals because anything below the bifurcation of the iliac, this aorta is regional node, and common iliac, I'm still doubtful whether it's non-regional nodes or regional nodes.
Absolutely. So you are bank on that. So absolutely, Dr. Ajay, you are right. So the right common iliac is not the regional node. So it is outside the regional node.
So it will become, sir, M1A disease because of non-regional nodes.
And if you see a bilateral seminal vesicle, which is T3B, and if it abuts the rectum, then it straight away becomes T4 even. So if we can higher the stage, so it can be a T4 in, and M1 also. So if we see this right iliac, so straight away for a asymptomatic gentleman, straight away it is a very, very high risk, or you can say a metastatic disease. So any other investigations, Tamajit?
Yes, so elderly gentlemen, so before starting therapy, if routine parameters are okay, blood and biochemical parameters, then two things are to be assessed. Number one is cardiovascular risk assessment, because ADT we are going to start, which have a negative impact on long-term cardiovascular health. And second thing is bone health assessment. So if as per FRAC scoring system, there is high chance of fracture, then always better to, before starting ADT, better to do a baseline BMD DEXA scan, and otherwise full cardiac evaluation in the form of at least 2D echo and other blood lipid profile also. So if there is any diabetes or hyperlipidemia, better to treat along with ADT therapy. If cardiovascular risk factors, along with taking into a cardiologist in the loop and managing the same. If the T score is high, then always better to add bone modifying agents along with ADT and other systemic agents for prostate cancer.
So our urologist colleague, Dr. Kashyapi, so what is the incidence of osteoporosis, or you can say in a male? So, and how often do you advocate a routine bone mineral density like we do so commonly in females?
I won't do so commonly a bone marrow bone density right at the beginning, but what my medical oncology colleague has suggested, that's a very valid point. It again depends upon how long the cardiac health here is equally important, because only the cardiac health will also decide the long-term longevity of this patient, because he has a locally advanced, but what the good thing about this patient is predominantly a nodal disease. There's hardly any skeletal mets. Generally, these would do much better than both skeletal mets and nodal disease.
Right. So if you see the statistics that's available, so we can see around 4% of males getting a osteoporosis, and that too after a long probably exposure to ADT. So something around 4 to 5%.
So I would actually may not insist on a bone density right at the beginning, especially if there are no skeletal mets.
Right.
But since he's going to be put on an androgen deprivation therapy, I would be starting him on calcium supplements, and I'll also check his vitamin D3 levels also at this point.
Absolutely. So has Dr. Kundu joined?
No, sir. Still he is not joined.
Okay.
Okay, you can go ahead.
So yeah. So what are the treatment options, Dr. Ajay?
So, sir, he's now he's a metastatic HSPC. So, treatment option is backbone will be this androgen deprivation, either surgical or medical androgen deprivation. Plus, I would like to add additional novel hormonal therapy, or maybe novel hormonal therapy only. So, he will be receiving, sir, this bone modifying agent, and that will be for prophylactic purpose once in 6 months, along with the androgen deprivation therapy, and I may add abiraterone or enzalutamide depending upon the comorbidity.
So he has no comorbidities.
Sir, if no comorbidity, then maybe abiraterone will be the preferred based on the financial. But based on the safety, I will like to give enzalutamide.
Okay. So Tamajit, so now, so are we ruling out any local therapy? So not today, maybe tomorrow. So are we ruling out the local therapy because our radiation colleague is not there? So are we ruling out local therapy at this moment?
No, sir. So it is a metastatic hormone sensitive prostate cancer. As per criteria, it's a low volume metastatic burden. So as per the HORAD study and as per the one arm of the STAMPED data, there is always beneficial in this low metastatic burden disease to add a local radiation to prostate, because in this subgroup of low volume metastatic disease, hormone sensitive metastatic prostate cancer, adding localized radiation to the prostate along with systemic therapy, ADT plus targeted agents, has shown overall survival benefit in both the STAMPED subgroup and both the HORAD study.
So Dr. Kashyapi, so any role of surgery? So today or tomorrow?
He is asymptomatic.
Right.
I'm not considering any role of surgical intervention as of now, or even 3 months down the line. I would agree with my other colleague that reassess him at 3 months, and I would definitely consider adding local therapy, preferably in the form of local radiation.
Right.
He's 79, he's asymptomatic, so I would look at the more than the effectiveness, also look at the minimal side effects. Surgery may have an option of may have a side effect of mainly incontinence, which may bother him in about 10 to 15% of the patients. As against that, there would be hardly any incontinence with a good radiation therapy. So, but some local therapy, yes, definitely.
Right. So this we have discussed the stage. So since he had a seminal vesicle, that make it stage T3C. But if you look at T4A, so the rectum, so probably T4A, and so this common iliac node is an N1 actually. So Tamajit, so what are the useful prognostic markers? So once you decide on any treatment of prostate cancers.
So predominantly these are the all the variables of the risk stratification criteria is used, like the clinical stage, Gleason score, and serum PSA, the baseline. These are the predominant, but along with that, what Dr. Vijay sir has showed, that few molecular panels can also be used, which can help in prediction and prognostication of the disease. But otherwise, predominantly all the parameters used for the risk stratification.
So would you consider doing a HRR or a germline mutations?
So for a non-metastatic disease, not.
No, so here it is a common iliac node.
Yeah, so in this case, the option is there initially for testing an MSI. If it is an MSI high disease or if it is a deficient MMR, then I'll go for HRR testing or at least BRCA1, 2 and ATM testing.
Right. So he actually received a 3-monthly Zoladex and he has been started on abiraterone, the standard dose, and is almost like 2 months plus now. So with the steroid, so he has been tolerating well. So now the similar case. So I'm just striking out the nodal part. So now bilateral seminal vesicles and aborts the rectum. So Dr. Kashyapi, so now, so what about the local therapy here? So we are taking out the metastatic part.
Same patient, different patient are we talking?
The same patient. So we have just striked up the nodal disease now.
So again, for a 79-year-old, local radiation, asymptomatic, hardly any urinary symptoms, not a very big prostate, the local radiation should be a good option.
Right.
But down the line, not immediately. Means I would always give a radiation 3 months down the line, not start upfront. That way it's better tolerated, lesser side effects.
Yeah, absolutely right, sir. So this patient is actually my own uncle actually. So he's my his father's younger brother. So so we know that, so for a watchful waiting for a locally advanced prostate cancer N0. So in a locally advanced N0 patients unwilling or unable to receive any form of local therapy, offer a deferred therapy policy using a ADT as a monotherapy to asymptomatic patients with a PSA doubling time of more than 12 months and a PSA of less than 50 nanogram and a non-poorly different tumor with the level of evidence is 1B. So neoadjuvant androgen deprivation. So before for a younger patient, eligible patients in a locally advanced does not improve cancer specific or overall survival. In a high risk patients, improved biochemical control observed with 81 gray even or more for EBRT, greatest benefits in the high risk group with a PSA of more than 10. IMRT with or without IGRT is the gold standard of EBRT in high-risk tumors or a locally advanced monotherapy with radiotherapy or permanent intestinal brachytherapy is inadequate. Outcomes improved by combining RT with androgen deprivation, often in the conjunction with the whole pelvic radiation. So my plan is that after 6 months, so he is going to get the next Joladex from few weeks from now. So at the end of 6 months, I will do a repeat PET scan, PSMA, and the MRI, and then we will decide on the local therapy.
Yes.
So theoretical
Yeah,
benefits.
he could also.
Yes, please go ahead, sir.
He could also be an option of for an SBRT at 6 months, based on what is the size of the prostate and the uptake in the prostate.
Okay, sir. Okay.
That would at least reduce the duration of radiation therapy. And currently, the radiation therapists believe in selected patients, even SBRT with 5 or 7 sittings would work equally well as for the as against the standard course of either 20 sittings or 25 sittings.
Right.
Yeah.
So theoretical benefits of AD-LRH before RT in locally advanced are ability to reduce target volume and potential cytotoxic synergy of radiation and hormone manipulation. Observation support neoadjuvant and concurrent AD with radiation, also a benefit to prolong AD. ADT starts either at the onset of RT for adjuvant AD or 2 to 3 months before for neoadjuvant, but concomitant component is crucial to potentiate RT. So here we are going to combine. So once we are combining SBRT or an external beam RT, then probably we need to continue that ADT part. So long-term ADT ranging from 2 to 3 years is recommended for a locally advanced rather than a short-term. So Tamojit, any experience of a low-dose abiraterone acetate? Because so suppose 79 years, the same patient, diabetes, and we have seen hypokalemia, hypertension is a huge problem. Hypoglycemias are a big problem. So any experience of low-dose abiraterone?
So predominant data is for M1 CRPC. So few patients, particularly what I prefer is, as you said, for the comorbidities, for diabetes or high chance of cardiovascular comorbidities, or due to cost issues, what we can use is with low fat diet. In spite of using 1000 mg OD in empty stomach, what we can do is 250 mg single tablet in with low fat diet, usually after low fat breakfast. The data is predominantly there for M1 CRPC in the form of a randomized trial also. Recently, there is a data published in this year, ESMO Asia from India, from the Indo-American Cancer Center, Hyderabad, by Dr. Rajapasar's unit, Senthil sir's unit. So what they have shown is their primary endpoint. If you take that at 12 weeks, the PSA reduction and symptom control, which is actually a short-term endpoint, not a long-term, but equal results, actually better results. And all pharmacodynamic studies and other phase 1 studies also have shown the similar results. So scientifically, with a low-fat diet, which contains 7 to 10% of the fat, there is chance of the bioavailability is more 4 to 7 times than a empty stomach dose. So in that sense, scientifically, it is, if you give with a low fat diet, it is always means you can reduce the dose to 1/4. So theoretically it's okay, and it is, we have data also, but predominantly for an hormone sensitive setting or for high risk localized setting, data is not there. Predominant clinical data is in the M1 CRPC. My experience, I also prefer to use in M1 CRPC also. In hormone sensitive setting, usually I use full dose until unless there is a economic constant from the patient's part.
So today abiraterone generic form comes at 5,000 rupees. So I don't think money is a barrier.
Yes.
So a decade back, when I started using for one of my doctor colleague in ophthalmology, so that it was 1,37,000 of Zytica. That was Johnson & Johnson, and now you get the same drug at 5,000 rupees. So medical oncology has come a long way. So the second case is a retired teacher. So 69 years. So February 2021, worked up with a local urologist. So comorbidities like hypertension and NIDDM, no addiction, no positive history of malignancy. So in December 2020, frequent involuntary urination and generalized weakness. So ultrasound abdomen on January 2021, prostatomegaly, grade 1 fatty liver. So the PSA you can see January 2021 and the February 2021, so 44.69, 44.96. And the PSMA you can see. So prostate gland appears enlarged in size. The size mentioned, increased PSMA uptake is noted in the ill-defined soft tissue. involving the right transition zone in apex and bilateral posterior peripheral zones of prostate gland. Bilateral semical vesicles are uninvolved. It aborts the rectum posteriorly, fat planes with urinary bladder, and bilateral pelvic appears well maintained. So Dr. Kashyapi, so now this is a younger patient, but have some symptom alerts and with comorbidities. And this is the PSMA PET scan in front of you.
I would want an MRI if it is not done, and then a biopsy.
Okay. So I don't have the MRI picture. So the biopsy was done. So it was an acinar adenocarcinoma. My Gleason score was 4+4. Prognostic grade 4, group 4, 30% involved of total prostate, LBA and PNI negative. So now what, sir?
So again, he could you just go back to the PSMA scan, please? We don't have an MRI, and how? So he didn't have any nodes.
No.
Fine. So again, this is a locally advanced, nothing in the bones. So he should be again high risk. He's younger, 69.
Right,
I
sir.
would treat him with an aggressive multimodal therapy.
Yeah. So what would be the first line of therapy for this?
First line would be an hormone blockade. I would reassess him at 3 months with a physical examination, the PSA value. If his LUTs have improved significantly, I would add a radiation. If his LUTs have not improved significantly, I would discuss the option of a radical prostate with him.
Okay. So he received 3 monthly Eligard and biclotamide for a month. And so this was again during the COVID time. So irregular follow-up. So, but you can see the PSA dropping and his LUTs improved, but he came to the casualty with a pain over the right hip, radiating to the right lower limb. So we did a MRI. So September 2021. So that showed all degenerative changes. So there was no evidence of disease here. So this is almost a year. So just the COVID second wave was out. So you can see the PSMA. So complete dissolution of PSMA expression. No evidence of PSMA, a bit nodes or something. So this is almost a metabolic CR. So this is post 3 or 4 doses, post 3 doses of Eligard.
Okay.
And so no clinical symptoms, PSA almost 0.9. So what next?
We should be offering him some therapy now. If his LUTs have disappeared, discuss with him the options of a local radiation versus a radical prostate.
Yeah, absolutely. So we discussed the same. So radiation, or we can at least consult the primary urologist and at least consider for a surgical opinion. The patient just lost to follow-up from March 2022, and he just came back last week. So almost 1 year. So he has been absent, and this is so this was okay. So lost to follow-up till February 2023. So now he came with a PSA of 21.6. This time breathlessness on exertion, general weakness, dry cough, done ultrasound, grade 2 prostatomegaly with PVRU, and
we need to restage him.
Yeah, so this is the recent PET scan which was done 2 days back. So you can see the prostate is enlarged with the posterior lobe 2.1 into 4. The lesion aborts the rectum posteriorly. Again, no nodes, no distant metastasis.
He's lucky.
So Tamajit, so there is a radiological progression, serological progression. Serum testosterone is 35. So what is the clinical state now?
Yeah, so if serum testosterone is below 50 nanogram per DL, that means he is
35,
still
35.
in. Yeah, so below 50, so that means he still maintains the castration level of testosterone. In spite of that, there is clinical and biochemical disease progression, no metastatic disease. So theoretically, then it will be a non-metastatic CRPC, theoretically at least.
Right. So this is a non-metastatic CRPC. So now Dr. Ajay, so at TMH, so out of 100 prostate cancer patients we treat, so how many are actually non-metastatic CRPC?
It is a very low. I think maybe below 5%.
Okay. But now there are so many approvals in this state. So, so now, so how do you define? So Tamajit, so definition, and what is the clinical implications of this non-metastatic CRPC? So as Dr. Ajay said, so less than 5%. So we had another meeting where less than 10%. So how do you define and what is the clinical implications of this entity?
Yeah, so definitions came in the era of 2015 to 2018, this new entity. If you look carefully, the ESMO guideline of prostate cancer in 2015, that entity was not mentioned even. So in 2018, NCCN onwards, this got a bit of highlight. So the definition given as per the different international guidelines is that there is more than 25% increase in the baseline PSA from the nadir value, but at the same time, there has to be a maintenance of the castration level of serum testosterone. And so the definition of absolute value of PSA can be different with respect to the primary therapy. If it is after radical prostatectomy, then there is 2 consecutive values of serum PSA and both should be more than 0.2 nanogram per ml, or after radical radiation, there should be 25% increase from the lowest nadir after radical radiation and with an absolute value of more than 2 nanogram per ml. So in all these situations, the serum testosterone level should be maintained at below 50 nanogram per ml. So that is the definition. And clinical implication is that as per the approved guidelines, if you look carefully, the NCCN, there is all apalutamide, darolutamide, and enzalutamide got category 1 level indication in terms of all phase 3 randomized control trial data. But the issue is two. The number one is when the definition came that time for an evaluation of a locally advanced or metastatic disease, there was not so widespread use of gallium-68 PSMA PET CT. So all these data and percentages and the prevalence of M0 CRPC in a clinical situation is based on the data of conventional scanning, including MRI, CT scan, and bone scan, not predominantly based on PSMA scanning. The second thing is that if we use enzalutamide or apalutamide before the development of actual metastatic disease, either it's a M1 HSPC or M1 CRPC, then we are actually losing one therapy options for M1 CRPC. So whether there is any impact or not, and all the clinical trials done with apalutamide, enzalutamide for M0 CRPC, the primary endpoint was taken as metastatic free survival. The overall survival was predominantly a secondary endpoint, and trials are not sufficiently statistically powered enough to show whether there is an overall survival benefit or not. Although the recently published data of all three drugs, the enzalutamide, apalutamide, darolutamide, have shown there is overall survival benefit, but predominantly the primary endpoint taken as metastasis-free survival, which was significantly better. So whether metastasis-free survival is actually important in clinical setting or not, and whether it's a surrogate for long-term OS or not, we don't have sufficient data. So like these aspects are there in terms of.
हमारा meeting खत्म हो गया, so you have just finished everything.
Thank you, sir.
So well read, sir. कल exam है जैसा लगता है तो मुझे. So Dr. Kashyap, so what is the key therapeutic goals for this entity, so non-metastatic CRPC?
See, the therapeutic goal again is to monitor for development of metastases. All these prostate cancer patients become hooked onto their PSA values, patients and their relatives. So any change in the value, small change, they will keep on jumping.
So now, anxious component, the psychological component is huge, right?
Yes, huge. So as my Samajit, he said ki all the definitions were in the era when PSMA PET scan was not used. Their definitions were based on CT scan and a bone scan, which again, in India, we have been using PSMA PET scan for the last 6-7 years. So anybody with this, I would definitely have a PSMA PET scan to know what is the source, where is the source. And that sometimes helps us in directing. Sometimes you might find a single metastasis somewhere, which you could give a local radiation again. So these are the how I would definitely use an PSMA PET scan to know the source. If not, then the options of what are, as he described, darolutamide, which has become recently, but what we had most of the time available has been enzalutamide for the last few years.
Right.
And again, the other option is a wait and watch observation.
Right. So Dr. Ajay, so how do you monitor such cases?
So for monitoring purpose, I will prefer this biochemical PSA monitoring along with the clinical assessment, and only on either a PSA rapid PSA progression means doubling, or any clinical symptoms like bone pain, I may consider some imaging. Otherwise, I'll just prefer PSA and clinical assessment.
Right. So there is
PSA
no,
doubling time.
yeah, PSA doubling time is important, as Dr. Kashyap said. So if it is more than 10 months, then you hold on.
Less than 10 months versus more than 10 months.
Right. So right. So the difference between so rising PSA while on ADT, serum testosterone less than 50, no evidence of metastasis is what we call a non-metastatic CRPC. So you are right, Tamojit. So in the era of conventional imagings, so now with PSMA, still there are some studies ongoing. So with that evidence of metastasis, we say it as a metastatic CRPC. So patients with a shorter PSA doubling time, if you see in these diagrams, you can see somebody who has a less than 3 months versus more than 15 months of PSA doubling. So there is a huge survival difference and the cumulative incidence of metastasis. So now, so yeah, so PSA doubling time of, so this landmark is like less than equal to 10 months. So the key therapeutic goals is that in non-metastatic CRPC are to prolong survival without disrupting patients' daily lives due to treatment related. So one can be extending OS. Second is maintaining quality of life, putting them on drugs which are toxic. Managing PSA and related anxiety, which Dr. Kashyap also addressed. So that is a huge. We have seen in ovarian cancer, somebody who has a serological progression. So that's in huge. So survival, quality of life, and PSA related anxiety. So clinical trial summary, it already been narrated by Tamojit. So now 3 drugs. So after enzalutamide, then darolutamide, and then apalutamide. So luckily we have all the 3 drugs with us, probably enzalutamide being the cheapest one, then followed by apalutamide. Darolutamide is a huge cost. So again, so you can see the incision of our friend in need. So PSA more than 10, doubling time more than 10 months. So Dr. Kashyap rightly said, so we are going to just observe the patient, somebody who is less than 10 months, then probably we are going to put up any of these second generation anti-androgens. So all these second generations non-steroidal anti-androgens have been approved in this setting. So how do you choose, Dr. Ajay? So now all these 3 drugs are there. So leaving besides the cost, so how are you going to choose? Tamajit?
So predominantly cost. If cost is not an issue, then we'll look on the toxicity parameters and we choose from the means patient existing comorbidities, and we try to choose the safest drug for a particular patient. But otherwise, if you look carefully, that all these enzalutamide, apalutamide, darolutamide, the toxicity parameters are almost very similar. All causes some form of fatigue, rash, skeletal related events, bone fractures, and cardiovascular problems. And along with, there are some specific side effects for specific drugs, like hypothyroidism is very typical for apalutamide, not caused by other 2 drugs. And again, the mental impairment and seizure episodes are typically caused by enzalutamide. But otherwise, skeletal related events and cardiovascular event risk is almost very similar. So I don't find personally any difference in toxicity, and at the same time, this means I have limitation because I have not used much of darolutamide or apalutamide. I have used predominantly enzalutamide, which is not a very difficult drug to use and almost a safe drug. So and otherwise,
I think we can take Dr. Ajay's opinion, because so at TMH he must have used all these drugs. So Dr. Ajay?
So sir, between these 3 drugs, I think the darolutamide may be a little bit safer, but otherwise no any great difference. So we can, if cost is not an issue, then I think for me the darolutamide will be the preferred drug. Okay. But clinically, I don't think there is much difference, but there is a slight advantage regarding safety for darolutamide.
So I think you must have used darolutamide and apalutamide both.
Yes, darolutamide we have on few patients, and I think this is one of among this will be the safest drug.
Right. So now we see that these 3 drugs have come from these 3 trials: the Spartan, the Prosper, and Aramis, on where you can see the hazard ratio of 0.28 is almost like the CDK4/6 in a metastatic setting. So there is a new thing coming up, is a PSA 90. So the median time to PSA 90 response was earlier, that is 3 months versus 5.2 months in the apalutamide and enzalutamide. So this can be one of the way you can select a drug besides, so one of the efficacy endpoints. So PSA 90 response which was earlier with the apalutamide and then compared to enzalutamide.
Again,
So
these are all
trials-
surrogate markers.
Right, sir, absolutely.
And there are no direct comparison between these three drugs.
So you won't have a comparison. So nobody is going, because
Nobody is going to do the studies also.
Right.
I know that.
So Tamajit rightly said, so beside the toxicity like fatigue, falls, bone fractures, cardiovascular events, rash, hypertension, hypothyroidism, pain progression. So on this, you can choose any of these drugs. So from an expert opinion, which I could collect, so that this gentleman is written. So I also tend to do a first PSA test quite early at the first visit after 1 month, more up for a psychological reasons, because I know that when my patients see the PSA falling, they are much happier. I tend to repeat the PSA testing once every 4 months. Regarding imaging, there are no strong recommendations or strong data. The consensus recommendation from the Advanced Prostate Cancer Consensus Conference is to consider doing an imaging once or twice every year, depending on the PSA doubling time. For patients who are responding to treatment, I will probably not image them more often than once in a year. So that's from my end. Thank you, Dr. Kashyapi, Ajay, and Tamojit. So the time is always right to do what is right by Martin Luther King. Thank you, Bijay, for this wonderful opportunity, and thanks, Samarth, for this slot. Thank you so much.
Thank you, sir.
Thanks a lot for this. The nice discussion.
Thank you, sir.
And I would now invite someone from Samarth for giving the vote of thanks.
Thank you, Dr. Patil, sir, and thank you, Dr. Ranjan sir, for that wonderful discussion and all the presentation that we had. Was really that ease mind looking at the way the presentations went on, case and the way one has to approach the other disease part. So with this, I suppose we end the two parts. So for just to let us end it formally. So for that, I would invite my colleague, Mr. Saurav Saha, to deliver the vote of thanks, and then we can wrap the meeting. Saurav, are you there?
Yeah, thank you everyone. Very good evening. It is a nice evening, and I really so happy to have all of you together. Actually, thank you, Dr. Vijay Patil sir, for you and for Dr. Ghanasham Biswas sir and everyone for making that sessions so nicely coincided, interactive, especially for the prostate cancer, where starting from neoadjuvant to adjuvant. With the intervention of medical surgery and radiotherapy, and with the different type of product or the drugs we are already available, starting from the innovators towards the generic markets, and usage, when to usage, what to usage, and how to usage. It is well coincided by Dr. Vijay Patil sir, well coincided and well interacted by Dr. Ghanasham Biswas sir and the panelist. With the most senior urology doctor is already available with us. Thank you all of you for being part of this wonderful sessions. And from on behalf of the entire team of Samarth, I really thankful to you, all of you. And as a sole intention of a company, a pharmaceutical company, an oncology company, we assure you to way forward. We'll continue this such events and meetings with such very interesting and very meaningful topics. Which will not only give a take-home message for the upbringing doctors in India from the different institutions, at the same time, which will give a very good take-home message to all of us. So thank you very much. Thank you everyone, and have a nice weekend. Thank you for your joining.
Thank you all.
For sessions. So thank you everyone. We can log out now.
Bye.
Thank you very much.